in the Center for Global Health and Social Responsibility at the University of Minnesota. Welcome to this International Women's Day webinar series on gender, COVID-19, and human rights. I'm really excited about this. We are really honored to have Dr. Senait Fisseha be our keynote speaker for today's session. The title of her talk is The Global State of Reproductive Health, Examining the Intersection of Health Equity and Politics. For details on other sessions in the webinar series, please visit the link that you see on the screen here. Today's session will be followed by a Q&A at the end. As you have questions during the presentation, please write them in the Q&A button on your screen, and we'll do our best to answer at the end of the session. We do have a very big audience today, so if we don't get to your questions, we apologize in advance. This session will be recorded and will be available online. So now it is my absolute privilege to introduce my friend, Dr. Senait Fisseha. I met Dr. Fisseha many years ago at the University of Michigan when I went there for my urogynecology fellowship interview. She warmly welcomed me into her home, even though I didn't end up going to University of Michigan. And I have been a huge fan of hers ever since. She is one of the most compassionate and committed person I know who works tirelessly on behalf of women everywhere. Professor Senait Fisseha is a globally recognized leader in reproductive health rights and a lifelong gender champion. She serves as the Director of Global Programs at the Susan Buffett Foundation, as well as Chief Advisor to the Director General of the World Health Organization. A reproductive endocrinology specialist, Dr. Fisseha previously was Chief of the Division of Reproductive Endocrinology and Infertility at the University of Michigan, Medical Director of University of Michigan's Center for Reproductive Medicine, and founding Executive Director of the Center for International Reproductive Health Training. While at Michigan, she also co-directed the medical school's Path of Excellence in Global Health and Disparities. Professor Fisseha was born in Ethiopia, and she earned an undergraduate degree from Rosary College and her MD and JD from Southern Illinois University, and a certificate in international human rights and comparative law from the University of Oxford. And with that, Dr. Fisseha, the stage is yours.
Thank you, my dear friend, Dr. Nardos, for that kind introduction. Although you did not come to Michigan for fellowship, I did not hold that against you, and I also hold you in equal, if not more, esteem. And I'm really grateful to you and the Center for Global Health and Social Responsibility for inviting me here today, and just super pleased to hear the cross-section of people that you've pulled together across campus to participate in this session. I'm just in awe. Global health and social responsibility. Wow, that is a huge concept. Honoring that is an enormous task right now, and this is, an intense time to have a career in global health. So I salute all of you who've come to this talk. I too have a big task ahead of me today, unpacking, as Dr. Nardo said, the title of the talk is The Global State of Reproductive Health, Examining the Intersection of Health Equity, Politics, and COVID-19. It's a long title for a huge, complex theme. So where do we even begin? Let us start by taking a moment to reflect on where we were 1 year ago. Many of us may not remember, but it was on March 6, 2020, just before International Women's Day, that the very first case of COVID-19 was reported in Minnesota. The first hospitalization in that state just a few days later. I clearly remember where I was. I had just canceled a trip to Liberia to celebrate the launch of President Ellen Johnson Sirleaf's new leadership accelerator as COVID cases were quickly rising around the world. By the end of March 2020, already 3,000 Americans had died. I remember so clearly the uncertainty of those days. I'm sure you do as well. Though we hoped it would soon pass, most of us had no idea that the next 12 months would bring this much catastrophe. So many missteps of our leadership, and frankly, a leadership vacuum in many ways, fueled the pandemic, which has just ravaged this country and so many other communities around the world. Today, 2.5 million people have died from COVID-19 globally. And more than 20% of those deaths have been in the United States. I guarantee that there is not one person here today whose life has not been touched in some way by COVID-19. And against the backdrop of this global pandemic, we saw xenophobia and racism and other systems of inequality laid bare. Just a few months after the first COVID-19 cases in the United States, in your very own city, George Floyd was murdered in broad daylight as the world watched in horror. His lynching was public and traumatic, and coming on the heels of the deaths of Ahmaud Arbery and Breonna Taylor, among so many other Black people who've been wrongfully killed in this country. The US is a country built by slaves, and so racism and racial injustice are deep part of its legacy, baked into our elite institutions and universities as well. So hopefully this should not and would not come as a shock to you. I have lived for 30 years in the United States, most of my career in global health. And I've done that as a Black woman, as an immigrant, and as an African. So believe me, I know something about racism and injustice. Yet the past year brought home to many more people in new and powerful ways. It sparked a new swell of protests for Black lives across the United States and the world. From outrage at injustice, we've seen movements. We elected the first Black and South Asian vice president, and the movement for Black lives, nominated for Nobel Peace Prize, has helped to ensure that racial justice is a priority for the new Biden-Harris administration. Suffice to say, it's been an incredibly intense year, one of tremendous change. Yet here we are, and you're here now, so we are survivors, and I think that is something to celebrate. This past year has already changed so much of what we know about what is true and what is possible. It has forever changed the face of global health. This matters whether you're studying public health or politics, or whether you're about to start your career or you are many decades in. With so many layers of injustice around us, where do we begin or work actually to make a difference? There are 3 radical ideas that I want to share with you today. I say radical not because you won't have heard of them, but because history continues to resist them, and they are not yet embedded in our approach to global health. But they must be if we want to see any progress at all. So the first radical idea is that women's rights, including reproductive rights, are fundamental human rights. We continue to see in every crisis, conflict, and community, women and girls will be disproportionately impacted. I am seeing this in my home country of Ethiopia, where I was last week visiting internally displaced people, or what we call IDP camps, near the northern Tigray region and throughout the country. A civil war has meant an overwhelming display of sexual violence and weighs heaviest on women and girls. It is utterly heartbreaking, and even more so because it has simply become the norm. The COVID-19 pandemic has shone a harsh light on our continued failure to value women's rights and women's bodies. Sexual and reproductive health services have been halted during the pandemic, deemed non-essential around the world. The Guttmacher Institute estimates an additional 15 million, mind you, 15 million unplanned pregnancies as a result of disruption of services. It also projects 3 million more unsafe abortions, which, as you know, unsafe abortion is a leading cause of maternal death and injury around the world. So that is 3 million women's life at risk on top of the risk of COVID-19 pandemic. There have been global spikes in domestic violence against women and girls, and increases in female genital mutilation during lockdowns. In the US, where we are now what they're calling the she session, with many more women losing jobs than men, setting us back decades on gender equality in the workforce. The US economy lost 140,000 jobs in December alone. All of them were held by women, the vast majority of them Black and Latina. So it's no wonder that women around the world are almost 3 times likely as men to report significant mental health consequences from this pandemic. We are bearing so much. I have to say I'm very excited and hopeful for the Biden administration's new Gender Policy Council, which could address some of these issues meaningfully in the United States. But regardless, there is so much work to do. The pandemic's ripple effects have cost women their lives and their livelihoods. They show the consequences of what happens when we fail to center the needs of women and girls and perpetuate systems that were never built for them. But now is the moment to change this grim reality I just described. It doesn't matter if you're not working, quote, in sexual and reproductive health, or do not even identify as a woman. Whether you are a malaria researcher or an infectious diseases specialist or a surgeon, you can and must be an advocate for gender equity. You need to know that reproductive health and rights are foundational to broader global health and development. We simply will not see progress without that. We are here to celebrate International Women's Day. The global theme this year is Choose to Challenge. I want you to remember that, choose to challenge. I've always found it curious that we, all the women in the world, get a day. I reject that idea and hope you do too. Let every day be International Women's Day for you, whatever field of studies you're in and whatever your title is. That means considering how you can center the needs of women and girls in all that you do. It means using the power and privilege you have to support the sexual and reproductive health and rights. I am here to remind you today that abortion is basic healthcare and that reproductive rights are human rights. So trust women, strive to be an ally, don't be afraid to use your voice. The second radical idea I want to propose to you is solidarity, especially now in the face of adversity and global crises. Over the past year, the Director General of the World Health Organization, Dr. Tedros, urged us many times to reflect on the concept of solidarity, along with humanity and unity. Let that really sink in for you and carry that with you in your work in global health. I don't mean solidarity in a simplistic way, which means, ignoring injustice or forgetting wrongs or pretending everything is okay. Rather, solidarity is about using privilege we have to ensure those most in need, most oppressed, and most vulnerable will be prioritized and centered. There is a powerful concept of Ubuntu, which originates from South Africa and speaks to the interdependence of us all. I am because you are. Solidarity is about stepping up even when we don't have to, because we recognize the humanity in all of us. It comes from understanding the full weight of injustice of the past and present and cultivating a fierce commitment to repair it. In the early days of the pandemic, there was the sense of connection as we all dealt with the same massive unknown. But that quickly dissipated to blame, and we allowed fear and our hoarding of resources, such as personal protective equipment and ventilators, to deepen division rather than transcend them. Now, as the COVID-19 vaccine is rolling out worldwide, we are seeing absolutely shameful levels of nationalism. As of March 1st, that's yesterday, 242 million COVID vaccine doses have been administered worldwide. Yet, globally, nearly 100 countries have yet to administer a single dose, including most countries in sub-Saharan Africa, a region of over 1 billion people. And 1 billion people, many of them are vulnerable. In February, the United Nations reported that just 10 high-income countries have administered 75% of the global vaccine supply. Just Canada has enough doses to vaccinate its population 5 times over. Whereas Rwanda, where I live now with my family, has yet to receive its official distribution of the vaccine from the COVAX facility. In some instances, young and healthy adults in wealthy countries are likely to receive vaccines before frontline healthcare workers in low-income countries, which 70% of whom are women. Dr. Tedros has called this inequity in the vaccine rollout a catastrophic moral failure. If that is a test of values in global health, we have not passed it. But it's not too late. It is the critical moment to integrate the concept of solidarity squarely in our newly reimagined field of global health. You don't need to feel guilty or apologetic for the access that you have, but can you commit to seeing the full inequity of the system and cultivate the responsibility that comes with your privilege to work to make the system more just? Finally, the third radical idea I want to propose to you is that white supremacy is actually the most dangerous disease vector in global health. Racism impacts everything, so racial justice must be the lens we take as we approach our work as practitioners, advocates, and change makers. It is some part of every day, so each one of us has a role to play either in perpetuating it or dismantling it. Within the healthcare system itself, we know, those of you that are in medicine have data in public health that show doctors regularly underestimate Black patients' symptoms and pain. This biases cost lives. New data shows that life expectancy in the United States dropped by 1 year last year, but nearly 3 years for Black Americans. Deep economic and educational inequalities, compounded over decades, have left their mark as well. In many ways, poor health outcomes are the culmination of these disparities. In Minnesota, Black people are testing positive for COVID-19 at twice the rate of white people and dying at much higher rates too. This is likely not a surprise to many of you. In Minnesota, racial inequities are so stark that they have been given a special name, the Minnesota Paradox. I'm sure you're familiar with that. It refers to the state's history of progressive leaders and policies, while also having some of the worst racial inequality in America. And yet, as Gianna Floyd, George Floyd's 6-year-old daughter said, "Daddy changed the world." People showed up in historic numbers to protest his murder and this ongoing injustice. It was like a great awakening happened on a global scale. I am sure that many of you marched. That action is not disconnected from your work as global health practitioners. As leaders and academicians, you must know that racial justice is not separate from health equity. You know that global health's very roots reach back to the history of colonialism, a manifestation of white supremacy. And there are so many ways in which that still manifests today, from who has a voice and who doesn't, who has the power to make decisions and who doesn't. So whether we are yet comfortable to admit it or not, each one of us is part of the system of white supremacy, and many of us have benefited from it. In our role as global health leaders, coming to terms with that and reckoning with our own power and privilege is an absolute crucial part of making any positive impact. So I invite you to lean into that. And if you already are, lean a bit farther. It is not comfortable. It's not a one-time thing. It requires a continuous and intentional effort. So where does that leave us? Are you radicalized yet? We all know, I'm sure you do as much as I do, we are up against huge forces of inequity and many, many years and layers of injustice, racism, misogyny, and a global pandemic. But if you remember one thing from this talk, remember this: times of great disruption create the conditions for radical transformation. This is there is a greater momentum for change now than I have ever seen in my lifetime. And there are so many reasons to be hopeful. So much of it is bubbling from grassroots, youth movements, and students, across this country, in the country that we have the privilege to call home. So if you want to change the world, start where you are. Start with yourself. Consider your identity and the privilege it brings. This is the foundation from which you operate in the world. Privilege is a tool, and all of us here have it in one way or another. If you're not using it intentionally to dismantle or to build, to actively repair or rebalance power, then you're using it to do harm. That's it. There is no in between. There is no neutral resting place. Think about this very deeply. This is perhaps the most radical thing you can do right now to transform the systems we live in. The reality is that none of us live single issue lives. That's what Audre Lorde said. Rather, we live incredibly rich and complex lives where we experience the intersection of power and oppression in many different ways. Therefore, we must approach our work with deep understanding and appreciation for that complexity. Racial injustice is health inequity. Sexism and racism conspire. Racism, misogyny, and economic injustice often go hand in hand. That is the reality from which reproductive justice is born. If abortion is legal, but misogyny, racism, and patriarchy are still alive and well, how much progress will we really ever make? To achieve reproductive justice, we need to confront systemic inequalities and our own roles in it. This period of deep unrest can deepen our resolve to fight for better because we deserve better. Women, communities of color, allies, LGBTQI, low income, marginalized community, all of us deserve better. So choose to challenge. Remember, that is our theme for International Women's Health Day or International Women's Day. Challenge yourself to see the system, to keep your eyes open so that you see exactly what is going on around you, including your own role. This is a critical moment for a new perspective on global health because the field, the world is like we have never known before. Despite the odds stacked against us, I'm incredibly hopeful about the change that is coming and what is possible because we are past the point of no return. And I know that each one of you, especially the young people in the room, will play a crucial role in bringing us towards a more just future. Thank you very much, and I will see you on the way.
Wow, Dr. Fisseha, that was a very inspiring and powerful message and very timely message for our times in the world, our times in Minnesota. Thank you so much for that presentation. You know, it's sobering to see how this pandemic and the unpredictable shifts in our political environment and the ingrained systemic injustice has laid bare the disparities and compromised the hard-won progress on reproductive health front. And this call to action really is a wake-up call for all of us. It's also a humbling reminder of how much has been achieved and how much more we still have got to go, and that it's time to harness the current momentum and build up on it. So thank you for that message. I do have some questions from the audience if you are ready to answer some of them. So the first question is actually from a member of our organizing group. Anna says, you know, you speak to the inequalities of women that have been exacerbated during the COVID-19 pandemic, and you also comment on any potential ways the aftermath of COVID crisis might improve aspects of women's health, reproductive health, and women's rights. For example, the pandemic finally laying bare some of these inequities might actually allow us to recognize and address these inequalities in the future. Can you comment on that? How can we harness this lessons learned to make a difference? And I'm going to add to that, what do you think should be the role of academic institutions like the one we have in that space?
Sure. Thank you, Rahel. I think first and foremost, you know, the pandemic did not create these inequalities, right? It just shone a light. It has shown us what happens when you sideline the needs of women and girls and also fail to invest in systems that address those needs. At the same time, more people than ever before are paying attention to how these inequalities are playing out. Many are also actively working to fix them. For instance, in some places we have seen, you know, self-managed care, including abortion, HIV care, contraception, become more accessible during COVID-19. When women have been unable to travel to clinics in person. For example, in the UK, the NHS has changed the guidelines to allow medication abortion up to 10 weeks to be administered at home. In addition, health tech innovations are coming online to fill gaps left in the pandemic's wake. So I think we're seeing a lot of progress. You know, these efforts are good. We need more initiatives that allow women the flexibility to access quality care outside of clinical settings. COVID-19, I think, also has presented us with unparalleled opportunity to support women's leadership. And in fact, I will argue the countries that have done really, really well managing COVID-19. In general, the pandemic response from Germany to New Zealand, from Taiwan to Iceland to Barbados are led by women. So we have seen incredible leadership from women stepping up. We've also seen unparalleled opportunity to support women leadership, especially women leading grassroots organizations who are closest to the work. Rahel, I'm sure you've seen this in global health, where we're used to Westerners flying in. Because of the flight disruption, now local groups have had the opportunity to rise up. In many countries across the world, women have demonstrated they can really lead through crises. Having said that, we still have some work to do, but I know we will rise to the challenge and really usher in a new era where women's health is no longer an afterthought. For your second question, what can academic institutions do? I will start out kind of the broader role of the US, not just US institution, but US as a country historically has been a leader in global health, although we suffered, tremendously in the last 4 years. However, the US has rarely been a leader when it comes to reproductive health and justice because of our own internal politics. This is where I see US academic institutions stepping in. It is our job as educators, as clinicians, as thought leaders, and experts to lead the way. For me, the pandemic has underscored that health equity is an issue that we need everyone to fight for. So efforts like your own institution, the University of Minnesota Center for Global Health and Social Responsibility, are already starting to fill the gap. Training practitioners, funding projects to advance women's health and needs, and calling leaders to invest in health system. I think the other enormous role that academic institutions do now, particularly in this difficult time, is sort of move away from sort of the ivory tower where we spend a lot of time in theory and a lot of kind of esoteric research to really practical implementation, sort of translating knowledge to policy and evidence and impact. I think we all are living in communities that are significantly impacted by the pandemic. And I think academic institutions can play a tremendous role in impacting and improving the lives of those around those institutions. And I think finally, and maybe most importantly, I think academic institutions have the enormous privilege and opportunity to shape the minds of future leaders who will fight for what's right for generations to come. So investing in young people and creating more opportunity for young people to be involved both in global health as well as disparities within the United States is, I think, a role that academic institutions can play.
Fantastic. That is it. That's wonderful. Thank you so much. I do have a couple more questions for you. One of the questions says, in my opinion, war is the mother of all public health ills, including women's health, especially in the context of global health. What do you think should be the role of women in reducing and stopping conflicts or wars? I mean, you kind of spoke to how women are rising up to this challenge during this pandemic as well. What would be the role of women during conflicts and wars? And attached to that question is also, the mention that the American Public Health Association, for example, has a list of 35 priority health issues and topics, but war is not included as one of the priority health issue, despite its huge role in creating and aggravating global public health ills. What do you think will be the advantages of listing war as a 36th issue? And should other medical associations consider including it as well?
Well, I don't think any of us could argue against that. I'm not sure. I mean, I don't have the direct statistics to say which one has the most impact, but there is absolutely no question about the devastation war and conflict cause, not just in public health, but in disrupting lives and livelihoods of people around the world. So if you look around right now, from Syria, that is entering its 11 years, like it is just completing its 10-year of conflict, to Yemen, from Afghanistan to now Ethiopia, war ravages communities, and disproportionately women and girls carry the brunt of this. And I absolutely agree that we need to see more women in conflict resolution and peace building, and there is ample evidence to show that. I mean, when you invest in women, you invest in communities, and in general, there is, both anecdotal and real evidence that when women are in leadership, they tend to go to conflict resolution before war. Frankly, I mean, there aren't that many women leaders in the world, right? There are a handful, but whenever women are involved in conflict resolution and peace building, and then we have, firsthand experience, for example, in sub-Saharan Africa, where countries like Malawi, when Joyce Banda became the president, that reverted into negotiation and political solutions and dialogue instead of, picking up arms. So I absolutely agree, and I think it would be wonderful if the American and international public health institutions start looking at war and its consequences as a massive public health threat, much like we have done with guns in the United States. So absolutely, I salute that and I support that, but I just could not agree with the person who asked the question that the impact of war, not just the physical harm, the economic damage, but also the actual mental, psychological, physical harm that war causes, is just massive. And this speaks to my soul, because currently, my people are being torn apart. And as we see in most conflicts, again, men show up their power and harm others by taking revenge out on women. So we are seeing rape being used as a weapon in war. We are seeing gender-based violence. And again, women and girls carry the brunt of the harm whenever there is conflict and war and displacement and any kind of calamity and crisis. So this is something that we all, as global health practitioners and healthcare providers and public health experts, should worry about and should call out, much like we do epidemics and other things, because it absolutely is devastating. And we're witnessing, if you look at the number of active conflicts in the world, from DRC to Myanmar, from Ethiopia to Syria, it's unrelenting, and it's usually innocent people who become victims, particularly women and girls. So how amazing would it be on this international, Women's Day and the month of, Women's History Month, that public health institutions and academicians push for including war and conflict as a public health threat. I would absolutely salute that, welcome that, and second that.
Thank you, Dr. Fisseha. And I mean, we both know the devastation that has been happening in Ethiopia and how that has really impacted maternal health and women's health in particular. One of the questions, just building on what you just said, was since you mentioned it at the beginning of your talk, were there any specific things that concerned you for maternal and child health when in Ethiopia? If you have any more to add, I think you pretty much described in general what war does. But if you want to say a few other things.
No, absolutely. What we know right now in Ethiopia is basically there is a near collapse of the healthcare system in northern Ethiopia and Tigray particular, which means, women don't have, and men and others as well. I mean, Ethiopia has made significant stride in taking services to the community. So most women go to what we call community health centers to seek care, including antenatal care, basic preventive health care, and even management of some of chronic diseases. And with massive destruction of these facilities and an active war, there has just been enormous setback in women seeking antenatal care, having access to safe delivery, postnatal family planning, and then, as I mentioned, with ravaging sexual violence, just being able to access services for, rape care and post-exposure prophylaxis and STI and emergency contraception, all these things have been massively disrupted. There's also been casualties from war. So the hospitals that were already struggling providing basic service now have to take care of people who are injured, from the war and are sustaining injuries. So certainly, especially since, we have done enormous work to convince women to deliver outside of their home and to actually see skilled birth attendants and seek, so it not only affects service access, but it will also affect health-seeking behavior if women who want the services cannot access them. So the impact of this is not going to be fixed just because the war stops and we establish healthcare facilities. It's going to have a significant and devastating impact on healthcare for all, but particularly those that are most vulnerable.
Thank you, Dr. Fisseha. It's very sobering to hear that. The next question really thanks you and appreciates your talk. The question is, what structural changes do you recommend we need to improve reproductive health around the world? And have you seen good models from around the world that have been successful?
Yeah, I think, each country is going to be very different. And I'm by no means, although our work spans about 84 countries, it's very hard to say, what works in one country may work in others. So it has to be contextualized. But I think essentially looking at women's health care as part of primary health care and not something special that gets done on the side. I don't go to a lawyer or a judge whether I'm going to have any other medical procedure. So frankly, it's only women's health and women's uteruses that just get regulated, and that essentially forces us to look at reproductive health very differently from other parts of health, other compared to other types of healthcare. So I think normalizing service delivery, integrating it, working on social norm. If you live in a society that continually devalues women and devalues women's bodily autonomy, and that starts very, very early, right? If you have a culture that values girls or boys more than girls and decides and allocates limited resources based on that value, we have a system that just perpetuates inequality. So from things like very harmful practices like female genital cutting to access to sanitary pads so that girls can stay in school, to early marriage, there are just so many harmful practices around the world that hold women back. And I think women's healthcare is a reflection of women's status in society. So if you're looking at countries like Scandinavian country, where, for example, there is very little pay gap between men and women, you also see women's reproductive healthcare, no issue around that, and access to services is not limited. So I think there are a lot of model in every context. Ethiopia is one country, for example, that had made historically significant stride in advancing reproductive health care. When abortion became legalized, so for example, the evidence shows us that restricting abortion does not limit abortion, it just increases unsafe abortion. So when Ethiopia liberalized abortion, maternal death from unsafe abortion dropped by about 30%, dramatic increase in about 30 years. There are so many countries, from Colombia and Latin America to Ethiopia and Africa, and now Rwanda, where I live, where there are extraordinary models. It doesn't mean that those countries don't have difficulties or struggle, but where you see enormous progress towards achieving a gender equal world where women's rights are not antagonized and women have a choice to form the family of their choice, have a baby, be supported when they want to have a baby, and be supported when they don't want to have a baby, and make that decision, not because their aunt or uncle or family or a church or an elder in the community says so, but a woman along with her partner decides that that is the right choice for her. And again, in the US as well, we have many states that have made enormous progress and others that are sliding back.
Wonderful. Thank you so much. I just had a couple more questions for you. So the next question is what your advice would be to donors, especially global health donors and implementers, in terms of how they should change their strategies in a COVID or post-COVID world to adequately address the inequalities or inequities that exist that have been exacerbated by COVID. Like you said, those inequities were already there. COVID did not make them so, but now we're seeing them a lot more clearly. What do you think? How do you think they should strategize?
I think, much like the Black Lives Matter movement, there has been enormous movement and conversation around global health. What does it mean? Who gets to make a decision? What is the model of the West, or the global North, as we call it in global health, sort of a system that is a unidirectional, where resources and expertise flow in one direction? And the kind of work, Rahel, you've done along your career, myself, we have tried to bring universities and academic institutions and partners along to say there is a fair and equitable way of doing global public health. Flow of information and knowledge and expertise does not have to be unidirectional. And I think what COVID has done and has showed us, when we create a system where we let countries and people who can actually stand on their feet depend on us, and something like the pandemic happens that disrupts flights and that disrupts communication, it just shows that the system doesn't work. So I think the biggest lesson for global health donors is that, one is we have to really invest in capacity building. 20, 30, 40 years ago, it may have been necessary to put all your money in the North. Now there are expertise. If I speak of my own country, Ethiopia or India or anywhere in the world, there are incredibly talented experts, but donors don't trust them. They still look for white folks to be the financial pass-through instead of funding these institutions directly. So I think that is going to change. There's also going to be accountability, both mutual accountability between partners, as well as grassroots groups holding donors accountable to ensure that they invest in voices and individuals and institutions so that this dependency will end. One of the things, for example, that we used to do when I was in academics at the University of Michigan is that if we go, our biggest partnership was with the University of Ghana. We used to call it Michigana. And for, when we send medical students, we brought medical students from Ghana. US institutions are notorious to look for partners in the global South so that their students could go on a 4 to 6 week, almost like tourism type experience, but not reciprocate the same opportunities for students from the global South. So I think we need to look at this very critically and ask our own values, and frankly, ask ourselves, knowingly or unknowingly, how are we perpetuating the system that is deeply rooted in colonialism and that perpetuates inequality? So I think donors have a hard question for themselves and others, but I think the movement has started. Of course, the saying that you hear is, there is nothing about us without us. So I think Global South partners are going to hold those of us on the other side of the Atlantic accountable about how we interact, how we behave, how we support, and how we collaborate. And I think there is a way to collaborate that is mutually beneficial. Just to give you a simple example, when I was at the University of Michigan and we supported a renal transplant program in Ethiopia, there was massive learning on both ways. I mean, the US physicians were going and learning the efficiency of the system, how to stretch our resources, and some of the implementation science researchers showed that about 95% of the success can be achieved with very limited resources. So all of the extra money that we pour in renal transplant in the US is to get us from like 93% to 98% success rate. So there is just so much co-learning that happens if you co-create programs. So my hope is that in our new reimagined world, there will be a compact between global North donors and institutions to get into really, frankly, some sort of charter or agreement to create programs in a way that mutually benefits both and not unidirectional flow.
Very wisely said, Dr. Fisseha. You speak to my core here. And as we know, a lot of times the work is dictated by the funders' priorities. And I think changing the minds and hearts of funders to invest in health systems strengthening and capacity building and bilateral benefits is huge in order to encourage people to even academic institutions to invest more in that area. I think a lot of people shy away from that because really those kind of collaborations and relationships take time. They require trust and they require relationship. They're not fast. And obviously they're also impacted by ups and downs of political instabilities. And there's a lot of things that pose as barriers, but they pay off in their long run, and they're the sustainable thing to do. So having a voice like yours, advocating for that at the level of funders and large organizations is huge.
Absolutely. I think, Rahel, you nailed it. If I can add one more thing, is vertical programming, right? Like, people's lives are not vertical. It's very easy to fund malaria because it's easier to measure, one single thing, or eradicate polio. But people's lives are very complex and you don't want people. So I 100% agree with you that the push to invest in health systems and complex ways of health delivery is going to be critical as we move forward. And countries that have done very well in the global South in fighting this pandemic are the ones that had invested in health systems and had a very strong primary healthcare system. So the other push that we need is the deverticalization of funding and just really taking a holistic health systems approach so that we can have lasting impact. And countries are prepared not only to deliver a comprehensive primary healthcare package, but also are well equipped to absorb the shocks of something like a COVID-19 pandemic.
Thank you. We do have a few questions, but in the interest of time, I do need to wrap this up. I really apologize for not getting through all the questions. There's a couple more questions. Dr. Fisseha, feel free to, I don't know if you have access to the Q&A thing to maybe answer them if you feel, just on text while I wrap up our session. This has been incredibly valuable presentation, and I hope it's that push that we all need to keep going and to really leverage the momentum of our current situations into real impact for women. So on behalf of the Center for Global Health and Social Responsibility, I want to thank Dr. Fisseha for joining us and sharing her insights into the global state of reproductive health. It has been an honor to hear your presentation. Thank you so much. A recording of this presentation will be made available on our website by the end of the week. Thank you as well to all the centers and programs who co-sponsored this series and have made it possible. This include the Global Rights for Women, and from the University of Minnesota, the Center on Women, Gender, and Public Policy, Human Rights Program, Women's Center, Interdisciplinary Center for the Study of Global Change, and our Center for Women in Medicine and Science. You can see their names on the screen. We're really, really grateful that this many groups came together to put together this webinar series. This is the first of our 3 webinar series. So don't forget to register for the upcoming ones as well. The 2 more events coming up. One is on this coming Thursday at noon, which will be a panel discussion with the title, Stopping Femicide, COVID-19 Brings Renewed Global Urgency. You can see the incredible panelists who will be part of that discussion. And details about registration on the slide here that you're seeing in front of you. Then next Wednesday, March 10th, I will actually be the speaker for that. It's also part of the Dean's Lecture Series and part of this International Women's Day webinar series. And my presentation will be entitled Obstetric Fistula, a window into disparities in women's health and a call for reimagining global health engagements. We hope that you will attend, and you've been such a fantastic audience. Thank you for your questions. And thank you again, Dr. Fisseha. Really appreciate you.
Thank you. Thank you for having me. Have a wonderful day.
Thank you.
Bye-bye.